Welcome to the fourth lecture of the 23rd annual Lefeber Winter Series on Aging series. I'm your host, Elena Volpe, and as you know, this lecture series honors the memory of Dr. Edward James Lefeber, who started as essentially geriatric medicine on this island in 1939. He taught internal medicine at UTMB and is starting actually getting geriatric patients preferentially because all his colleagues didn't want to deal with them. And so he became a champion for geriatric medicine and actually was the starter for what then became the geriatric medicine division within the Department of Internal Medicine here at UTMB. He also later became the director of what is today the Meridian Retirement Community. And before he died, actually, the Division of Geriatrics started at UTMB. So today I'm really pleased to introduce Dr. Goldie Byrd. Dr. Byrd is the director of the Center for Outreach in Alzheimer's Aging and Community Health. Dr. Byrd received her Bachelor's of Science degrees in Professional Biology and Biology Education at North Carolina A&T State University. She received her PhD in Microbial Genetics and completed her postdoctoral training at Meharry Medical College. After graduation, she took a position as an assistant professor at the Tennessee State University, and later became an associate professor at North Carolina Central University, and then a professor at Duke University. And after that, she took a job in the school where she's at right now as the chair of the Department of Biology and subsequently as the dean of the College of Arts and Sciences at North Carolina A&T State University. Where she's overseen a major growth in a school, which my understanding is that eventually had to be split up into two large colleges because it was huge. And so a little more than a year ago, she became the director of the Center for Outreach in Alzheimer's Aging and Community Health, which is now growing. Dr. Byrd's research focuses, as you've heard earlier, on Alzheimer's disease in African American elders with a specific interest in the genetics that underlie the disease. She's published more than 50 papers and book chapters and has been well funded for her research efforts. She was awarded a multi-million-dollar grant from the National Center on Minority Health and Health Disparities to establish genetics research capacity at North Carolina A&T State University. She also won support to study genetic susceptibility of Alzheimer's disease in African Americans. Dr. Byrd has mentored many students and fellows and also been very active in community outreach. And she's been successful in obtaining philanthropic donations to establish and grow research and educational efforts. She's mentored many students and fellows too. She has received many honors and awards, among which are notable her appointment in 2016 by the U.S. Secretary of Health and Human Resources as a member of the National Advisory General Medicine Sciences Council, and the Presidential Award for Excellence in Science, Mathematics, and Engineering Mentoring, sponsored by the National Science Foundation, NSF, and awarded in 2009 at the White House with a nice ceremony. Now, we are really honored to have Dr. Goldie Byrd today as a speaker for the 23rd Lefeber Winter Series on Aging, and the title of our talk is Alzheimer's Disease in African Americans, Unraveling Genetics Using a Campus and Community-Based Model for Recruitment, Inclusion, and Empowerment. Thank you, Dr. Byrd, and join me to welcome her.
Thank you, Dr. Volpe. Good afternoon. It is my great pleasure to be here today. I've had a wonderful day. I've spoken to a number of faculty members, and we just had a blast. I think every person we had commonalities and certainly an interest in diseases and conditions of the aging and how we might be more inclusive in our work. I certainly want to thank Larry and Kelly for the invitation, as well as Dr. Odenbacher, I think he's back there, and all of you for being here this afternoon. I'm going to I have a lot of slides, and you can probably tell by the title of my presentation that I like words. I am more succinct sometime, I promise you. So we're going to move quickly through this, and I believe we should have some time for question and answer. So as I'm really happy to be here for this lecture series today, and as you can see with the first slide, I have focused over the past 15 years or so on genetics of Alzheimer's in African Americans. Primarily, you will see in just a few moments, this is a disease that, of course, that affects everybody, but it is one that disproportionately affects African Americans, and African Americans have a disproportionate burden with disease, with getting a diagnosis, with management of care, and so on, and yet we are so absolutely missing in research and clinical trials. So we're going to push forward. So I'm going to talk to you a little bit about Alzheimer's disease. I understand that there are members of the community in the audience. I'm very happy. I'm always happy to see community come in. And then we're going to talk a little bit about investigating genetics in African Americans. Not much, though. I promise you I will not talk genetics at this hour of the day. And then Alzheimer's and community, and then our university model for, as many of you know, just a little bit about Alzheimer's. It's the most common form of dementia. The primary risk factor, as we know it, is age. And about every 6 to 6 seconds, someone has Alzheimer's disease. Currently, there is no cure for this disease. There is no drug which slows it down. Quite frankly, it goes in one direction, and that's not a good direction at all. As I said, it is the most common form of dementia, and this is something that people ask me about all the time, so I just thought I'd put a big umbrella there to let people know that it's just that the dementia is an umbrella term that refers to some memory loss and some changes in activities of daily living, but there are many different kinds, and of course Alzheimer's comprises about 70 to 80% of those. Again, it's the 6th leading cause of death. And that's something many people don't realize. I mean, there are diseases and conditions that rank really high and on everybody's radar, but this is one that many people tend not to know about. And of course, we believe these numbers that I'm presenting today are certainly underrepresented because of how we count people with Alzheimer's disease. And of course, in North Carolina, you can see that we have a really big problem in our state, and you do too here in Texas, by the way. Over 5 million Americans are living with Alzheimer's, and again, we believe that number is underreported. About 5.2 million of those people have the late onset, which is what we know more about, and about 200,000 of those people have what we know as early onset Alzheimer's disease. These are, the causes are different. And of course, with early onset, we have a much better feel for what causes it than we do with late onset, which is where most of the cases are in late onset Alzheimer's disease. 1 in 8 baby boomers, if you look around in this room today, you'll see baby boomers, those people born from about 1946 and about 1964. I will not ask you to raise your hand, but you know who you are. So about 1 in 8 of you will have Alzheimer's disease unless there's an intervention or a cure. And of course, we now know that when we think about Alzheimer's disease, that there is this period long before we have signs and symptoms where we know that a person has Alzheimer's disease. So if we get a diagnosis, usually about 20 or 30 years before that, we know that that person has had Alzheimer's for a long time. And of course, it goes from those very basic things like memory loss and confusion, so forth and so on, until it gets to a point where a person is unable to speak, unable to talk, unable to bathe oneself, and usually is relegated to a bed. Quite frankly, it is one of the most feared diseases. No one likes to think that he or she is going to lose their ability to think and process and execute executive functioning. So we always just put this in here just to remind everyone of the dilemma that we have. The complexity of this disease is so great. And yet there is hope because There is so much wonderful research being done around the globe. So there is hope, and now there's a little bit more funding from the federal government. We are very grateful for that. But it is a really severe disease and something we will have to understand and do better about, or it will break the bank. The Alzheimer's Association reports last year in 2017 that it cost this country over $250 billion for the first time. This is expected to increase unless there is an intervention. And of course, we see what this disease does to our brain if you look at scans. There is hope again, as we said. You see Alzheimer's all over the place. You see articles like this, and people are reading. By the way, the one on the right is our Washington Post article from last summer. We're really excited about that article because it went so far and it reached so many people. So understanding Alzheimer's as a health disparity. What we know is that about Hispanics are about 1.5 times more likely to have Alzheimer's disease, and African Americans are at least 2 times and maybe 3 times more likely to have Alzheimer's disease. Our goal was to initially ask the question, why do African Americans particularly have Alzheimer's more? What are those, if there are genetic factors that are specific to this group of people that causes an increased prevalence of Alzheimer's disease? So we wanted to know, again, African Americans 2 to 3 times more likely. So people ask us all the time, why do you want to study Alzheimer's disease in a specific group? So we have to be able to answer a question. So these are the kinds of things we say. So genetics of Alzheimer's in African Americans is unclear. First-degree relatives we know are more likely to get Alzheimer's disease. The apogenotype is elusive in African Americans. Of course, it runs in families. And we have, again, more burden of care, late diagnosis, care management issues, and yet we are underrepresented in studies. These are some of our patients. And so we see patients who have sometimes 4, 5, 6, 7 people in a family with Alzheimer's disease. And you can imagine the burden of this disease when one person has it. But when you have 4 or 5 people in a family with Alzheimer's disease, and everybody's going broke by the day, and not only broke with money, but broken in spirit, you can only imagine the desperation of these families. So I began this work with a group of people who were really hotshot folks in Alzheimer's genetics at Duke University about 15 years ago. And I went over, as Dr. Volpe said, I was trained as a microbial geneticist and decided that I wanted to change my focus to human genetics and study a disease that was clearly a health disparity and one that I had firsthand experience with. So I went over and talked to these folks, and I said, I want to do this. So I went on sabbatical because I wanted to take advantage of what we knew about the Human Genome Project. The Human Genome Project was being released about this time, around 2002, 2003. And I wanted my students to have a good dose of the Human Genome Project and what that was going to mean for medicine and for their lives. So I went over to Duke, and I said to the center director that I wanted to do this study, and I wanted to do it in African Americans. And she said to me, you have to be out of your mind, Goldie. She said, I can put up a sign in the elevator and get all the white people I need, but I can't get those blacks in the study. But it's something I wanted to do. I've been wanting to do this a long time. So I was glad I had my own money to do this sabbatical because you know how that goes. But she wanted to do it, so that was an open window for me to go up to NIH and talk to some people about how do we get enough African Americans in a GWAS study, and we do it without hurting anybody's feelings. And so that's what we did. So we decided that it was going to take a lot of work. It was going to take a lot of work in convincing individuals, not only participants, potential participants, but also the community, the scientific community of what we were trying to accomplish and why it was important to do it. But we did it. So we devised this strategy and decided that before we began to recruit the first individual, that we needed to know something about the community in which we were recruiting, or from which we were recruiting. Now, I did say we were recruiting African Americans. And in case you hadn't noticed, I happened to be one of those people. But I did not know how to go into this community and recruit people with the kind of dignity that would leave them unscathed in their mind. I simply did not know how to do that. And neither did the people I was working with. So we had a little bit of a dilemma. So we decided that the first thing we would do is to go into the community and ask people about it. What would it take? What is the barrier? What do you remember about Tuskegee? What do you remember about Duke not allowing you equal access to health care? Does that make a difference? What do you need from a research staff? What do you need from us? Are you participating currently? These are the kinds of questions that we asked this population, our target population. We felt like it was important to go into the community because we didn't know the answers, and it was not wise of us to assume that we did. So we started with the research, and then we went out and just made some community friends. We partnered with people. We still do that today. And then we just did a blast of awareness. We just went out into the community, lots of grassroots. Then we had to figure out some reciprocity for the community. And then, number 5, is where we began to recruit. And some people thought that was a total waste of time. But I'll tell you, it wasn't. So the study was seeking at that time a couple of thousand individuals, and we partnered with, and some of the people in the audience today know some of our collaborators. We talked about that. And so we brought these individuals from these universities together, and we began to conceptualize how we would not only get the genetics done, but how we would recruit thousands of African Americans. And then our more recent study, where we were doing family studies. So here we had a situation where we had a population of people that was distrustful of research and medicine, that have an overburden of disease that was extraordinarily underrepresented and studied. We did a PubMed search when we began this work, and I think it was like 0.0024% of African American papers in PubMed or something like this, some just grossly inappropriate number. And yet we had this dilemma. We really needed to get into the community, and we really needed to get these folks into the study. So now we're dealing with families. So in addition to cases and controls, now we're looking at families of individuals who have at least 3 people in the study, cases and controls. So originally cases and controls, now families. So you're talking about uphill battles, my goodness. If we didn't have a plan, we knew we weren't going to reach our targets. So some of these people had no direct contacts. Some of the families had people living all over the place, somebody in North Carolina, somebody in California. Some of the family members were dead. People were still in denial about this disease. Again, it's one of the most dreaded diseases that we deal with, and so people were in denial. Okay, that's good. And then people were really afraid about releasing their information. We know the drill. There are many researchers in this room, so we know the drill. We know what people are afraid of. People were afraid that their DNA was going to get in the wrong hands, and some people still are afraid of that. And then, of course, many loved ones that we needed had passed away. So again, there was reluctance to adding just one more thing to the plate of caregivers. So we had all of these things that we needed to address. And then, so this is a paper that we presented last year at the AIC meeting, where we actually looked at how we could best get families to work together for this family study. I'll tell you a little bit more about that in a few minutes. So we asked about 500 people about this work, what we needed to do. And we used an intergenerational sample because we were really interested in getting the young people, that next generation of people interested in the concept of participating in studies. So we were not only interested in people 60 and above, but we were also interested in the next generation of people and understanding what it meant to them to participate in our study, or what Alzheimer's itself meant to them, and how were they dealing with it. And on our campus, many of our students are caregivers. They send money home to their families. They see their parents dealing with them in college and their parents on the other end. They see parents who lose their marital relationships. They see parents losing their family income, parents who can't go to ball games and recitals because of this disease. So they are dealing with this disease, and it is stressful to them. We have studies that show that. So when we did this study, this is the kind of thing that we learned. We published this paper just not too long ago, actually, that the community needed to be trusted. We needed to trust them, and they needed to trust us, that our materials and our work and what we said to them was culturally sensitive. It was clear that there needed to be some reciprocity, and that wasn't terribly a lot, but there needed to be some. And that sometimes they needed us to provide support in other areas. They wanted updates. We call this our social contract with them. You help us, we help you. Sometimes they needed support with family. How do we get support for someone that we're caring for? And they wanted to have access to professionals. Well, my goodness, we have 600 faculty members on a college campus, and I just kind of viewed that as a lot of professional support. And where we couldn't find it in our center or in our group, we had access to people at the hospital, at the medical school down the road. And so we figured that we could provide some support in a number of different ways. Now, if we delve into this community engagement, it requires funding, it requires appreciation and investment in communities. At the time we were beginning to do this, NIH would not budge much for us to do this. Now it does budge. We are very happy about that. I was talking with one of the faculty members today. We just pulled up some of the RFAs that NIH now will support for community engagement. We learned a lot of different things, including a lot about willingness to participate. About 50%, more than 50%, and each one of these age groups said that they would be willing to participate. And I'm not going to go over a lot of this, but this is a very important slide. You know why? Because many researchers for many years, even after the 1993 Revitalization Act, which says that you are required to engage minorities and women in studies, of course, researchers haven't done that a lot. So in spite of that, people say blacks aren't willing to participate. And that is indeed true in some cases. Just like people say Hispanics will not participate. And that is indeed true in some cases. So what we had to do was to figure out what are the situations in which they will participate. So this is really important to us. So at that time, as we began, I was chairing biology and I was deaning, and I just felt like I needed to take some liberties. So I used just about everything we had, like our newspaper and our radio and our television station on campus, because I could get that for free. And then we had events that we could get for pretty much free, with just a little bit of support from folks. And so we did this big grassroots awareness piece. At the top, we did this Keeping Memories Alive. We had galas, we had community sponsors, and these were with all kinds of messaging about Alzheimer's disease, about African Americans and the importance of improving health to prevent certain kinds of diseases and conditions. So these were just really, just flooded the community with grassroots efforts initially. And again, when I became dean, I had all these kids, I had all these departments, I held all these areas, and guess what? We said, anybody who wants to do some aging research or some stuff, just come on over here. And people did that. They actually did that. Again, we used all kinds of ways to message. We had a person in our communications department who oversaw that to make sure that our messaging was grade level, that it was clear and concise, and people could understand what we were saying, and that it was sensitive to the needs of people. And we just had all kinds. This is just a systems approach of people who were interested in doing something with our research. We even invited celebrities to campus, like Ruben Studdard, who wrote a nice song for us. One of the faculty members just had to listen to his song, who wrote a song for us, and he came down to over to North Carolina to perform the song. There is B. Smith and Dan Gasby, and B is a real big celebrity. And in the height of her career, she had early onset Alzheimer's disease. We have a chapter in their book, as a matter of fact. We did walks with the Alzheimer's Association. We did learning parties. We engaged art students. This is our chancellor on the right. And, after he saw that we were really up to something, he got involved with it. You know how chancellors and presidents are. You got to kind of convince them that you're onto something, and then they get on board. And so then we decided that he needed to help us with some outside funding, with some private funding, and he did. And so this piece behind you there, that was a piece that we commissioned some art students. So we had art students to do things like that. They would come over to our center. They had to learn about our Alzheimer's disease, and they created pieces like that. This is what our university engagement looked like. I'm going to talk a little bit about Aggies Against Alzheimer's. We've got community volunteers because we could not afford to hire everybody that we needed. So we had to organize ourselves. We currently have service learning projects, interinstitutional internships. People from UNCG and North Carolina Central students want to come and share and learn from our center. One very interesting thing is that, again, we engage students as participants. And the idea is to train students to understand the social justice behind participating in research and clinical trials. And then we're creating a faculty fellows program, which we're really excited, which faculty members can come over. And I believe we have a donor who's going to fund that so that our faculty can come over and spend time in our center. We even dressed up the band, let them wear purple. And so on the big Jumbotron were messages about Alzheimer's disease. We did Purple Sundays with the Alzheimer's Association. We published some of our work so people could know. And we kept the community not only in the scientific journals, but also in publications that they could read and they could understand, kept them abreast of what was going on. So after we had years of grassroots efforts and we were beginning to recruit, we decided we needed to do something more substantial. We needed deeper dives. We needed more evidence-based work in our communities. And so we convinced one of the vice presidents of Merck, of Merck Manufacturing, that we needed a space on campus that was funded and that had staff in it where we could invite people to the campus and that we could provide opportunities for them. So bridging the campus, the bench, and the community became our motto. This is one of the areas we have an engineering program college on our campus, and we had an engineer to build this space to look like a family room, a house. And it's kind of fuzzy, but but you see chairs, and you probably can't see the bed over there, but there's a toilet and a refrigerator. And we do a lot of workshops in this space. We have another space that we just outfitted, and it's a multi-purpose room where people can come in. So it's not only that we went out, we felt like it was important for people to be able to come to our center. So it wasn't just a building with office spaces in it. It's a space where people can come. They can learn. When they come to our support groups, an hour and a half turns into about 3 hours. People actually learn to network there. They find support there. And so they just love coming. So these are the areas that we have in our space. One of the things that, and I won't go into that kind of stuff. So it was important then for us to, as we were recruiting individuals, and notice I'm not talking so much about recruiting individuals, but trust me, it was happening at the same time. This particular paper on your left, it is the paper that it's got a gazillion names on it because so many people helped with this, but 6,000 African Americans are in the largest GWAS study, and that took years. and a number of laboratories across the country. But that is a seminal paper. It was at that time the largest genome-wide association study in African Americans with Alzheimer's disease. So we're really happy to be a part of that. But then on the right, we're just as proud of the inclusion work that we do and the work that says we are figuring out ways to recruit African Americans in studies. So again, we listened to the people who we were interested in. And so we created things like, one of the things they told us was they wanted support groups. And they wanted to do more work. They wanted us to do more work around their daily lives. And their daily lives, many of them were taking care of people with Alzheimer's. Again, 15 million Americans provide unpaid care. 2 out of 3 of these people are women. And of course, 2/3 of the people with Alzheimer's disease are women. And it's really interesting because now we're getting to know more about some of the reasons why that might be happening. I won't go into that. And then we did Millennial Caregivers. Again, we've already talked about this, the importance of understanding what's happening with Millennial Caregivers. And all of us know all of the many of the kinds of things that are impacted when you are a caregiver. This is one of the things that we did, an annual caregiver education conference. Now we bring about 400 people from across the state of North Carolina to this annual caregivers conference each year. And each year we collect data from people. And we started with about 60 people. But each year we collect data that inform us about what kinds of people are coming, what kinds of folks are showing up, what kinds of needs they have, what kinds of resources they have in the community. Many people are still very much isolated with Alzheimer's disease. They're trying to do this alone, and they don't have much help in community settings. These are some more things that they told us about our caregivers, and even how do you receive information, or if you receive it at all. So one of the things that we're creating now is a COAACH Caregiver College curriculum, and this curriculum will bring people from across the state of North Carolina to our center. Eventually we will do it electronically by the web, but it will bring people to the center. They will learn through modules. They will take information back to their communities, and they're required to take at least 3 activities back with them. So we're designing that, and that launch will be this fall. The idea is to get as much information out to communities as possible, and to do it in a way that we're not required to do all of that work because we are small staff. We also have a family navigation program that we're pushing out. And again, many people across the state and across the nation are dealing with this disease in isolation. So we want to work more with families to ask them to work together better in managing the care of this disease. So again, until the story of the hunt is told by the lion, the tale of the hunt will always glorify the hunter. So what that says to us is that if African Americans are underrepresented, African Americans have to tell African American stories. And they have to tell it in such a way that they can listen, that people can listen, and in ways that health is improved. So again, I want to just expand on student engagement. Very excited about our student engagement. I can tell you that our students come and to our center, and they volunteer all the time in many different ways. And one Saturday they were participating in an Alzheimer's walk. And they came back and they decided that they wanted an organization on campus. So we just submitted the charter for the Aggies Against Alzheimer's chapter on our campus. We've got about 100 students who signed up, and they will participate in all kinds of things in our center. They're already participating as caregivers, ombudsmen, interns. We have graduate students, student participants in studies, and students who serve in advocacy roles. And these are I'm just giving you some of the examples of the things that we do with a small staff. These are some of our interns right now. The one on the right at the bottom is an English major. She's a technical writer. Her mother had Alzheimer's disease, and she wants to be able to write about diseases and conditions of the aging. The 3 of them are biology majors, and the one at the top left is a gerontology intern from UNCG. They are participating in a big book club project to raise awareness about Alzheimer's disease. This is one of their projects, and this is when Marita Golden is the person who actually wrote the Washington Post article. And so they are taking the book clubs, and they are using this book as a guide for raising awareness against Alzheimer's disease. We also involve our community. We bring stakeholders to our center. We just had a breakfast this past August, and about 30 organizations in the community, including the Alzheimer's Association, the Health Department, et cetera, et cetera. And we come together to network to see how we can do collaborative things. So if we're doing something on our campus and we need their listserv, we shoot it out to them, and they do that with us. They have more money than we do, so it's good for us to collaborate. We also are involved in advocacy from our center. I co-chaired the committee to plan a state plan for Alzheimer's and dementia in North Carolina, and from there we received a legislative appropriation for a state registry in brain health and prevention. So we receive a lot of awards and think different things and recognitions. These are the things we do from our center. But we believe that we have a good social contract with our community. We're in contact with them all the time. We're becoming much more technologically savvy, so we're not having to do some of the things manually that we've been doing. And this is really, though, why we do what we do.
I am so grateful. I might start crying, but I am.
She's laughing to keep from crying because she has a tough situation.
For Coach, because where I didn't have knowledge before as to how to relate to my mom, who is no longer my mom, she's become a patient. She's become someone I happen to love that I'm caring for, but Coach has given me skills, strategies, resources. I've been able to connect with other family members who are going through the very same thing, and some people who are further along. But just knowing that I'm not by myself, and it's been an outlet for me. It's a chance for me to share my feelings openly without being judged, because other people are able to understand and they're going through the same thing.
So what have we learned from this kind of work? Well, African Americans will participate in studies. Hispanic Americans will participate in studies. Asian Americans, et cetera, et cetera, et cetera. We have to learn what it takes. We have to simply take the time to understand what it takes to get into communities, to understand cultures. We believe we did first things first by understanding the challenges and the burdens and the barriers for participation. We have to be present. We have to raise awareness. Our goal is that there won't be so much stigma in the next few years around this disease, that people will begin to talk about it, that families will begin to talk collectively about it. Imagine 2 or 3 people in the family, you don't know where the will is. You don't know what a healthcare power of attorney is. And that is one of our top requests, the legal and professional side. Then we have to build strong partners in the community, people who are influential. We call them stakeholders. You might call them something else. Often we have to leave something in the community. We might not create a center for outreach, but we have to leave something, depending upon the group. Diversified engagement networks. Have to beat the bushes sometimes. And don't quit. There is hope. And then in addition, there just might be some other good things out there that we leave behind. Greater awareness, improved ways to improve health in general, because we really don't know how to prevent Alzheimer's disease. So what we say to people is that a healthy body equals a healthy brain most of the time. supposed to be a healthier lifestyle at the end of that. Navigation. What do you do when you get an Alzheimer's diagnosis? Where do you go? What are the resources? Families need to know, because some of them may not have a PhD or an MD. The family dynamics for some of these families is absolutely horrendous. Sometimes people fly, like flying roaches. You open a door and roaches fly. People fly when there's a diagnosis, still. Rather than rallying around that one person usually who's going to take on most of the burden, many people say, well, I just don't know what to do. Or I'm scared. Even worse, no, she really doesn't have anything. She's just getting old. Just a little senility, a little Alzheimer's, just a little forgetfulness. So we have to educate people. Families need to be knowledgeable, irrespective of race, culture, ethnicity, socioeconomic status. We have over 90% retention in our studies. And if you notice, I talked a lot about outreach. I haven't talked much about getting people in studies. But I can tell you that we spend less money on recruitment now and less time because we've done first things first. I just want to acknowledge the folks who help us to run. Of course, our team and all of our study participants that we honor and we dignify always in the way we treat them. All of our collaborators and our funders, and all of you for being here and listening. It's kind of warm. Thank you very much.
Thank you very much for the nice talk. And now the talk is open for questions. So if we have any questions from the audience.
Yes, sir.
Yes.
Can you give us the symptoms of the first stages of Alzheimer's?
Yes. So what usually, one of the first things that people use, and there are many MDs in the room, so I should probably ask you all to do this, but one of the first things that people see is repeating, saying the same things over and over again, depending upon where they are in that stage. But that's one of the ones that sticks out with everybody, And then some people, because they don't know, they'll say, "Well, I just told you that 5 minutes ago." What they don't realize is, and I apologize, I didn't put my brain up there, but what they don't realize is it's not that person doing that, it's that part of the brain that's really dying off, okay? And then there could be, as time goes on, there's confusion, there's the inability to do some executive things like writing a check and paying bills. We have a person in our study who bought 3 brand new Cadillacs in less than a year. So he was making a lot of big mistakes, So that confusion and really becoming a victim of, well, we're all victims of fraud, and we're not victims, all of us, but we're certainly sitting ducks for it if we don't do the right thing. And so, just confusion. Sometimes people get very combative. They will curse you out. They will hit you, as time goes on. But certainly the confusion, the inability to think, and sometimes the inhibition, they just might pee on this podium, take the clothes off. Those parts of the brain are dying off. And so it's more than just getting old. We're going to lose some memory as time goes on anyway, but Alzheimer's is different. This is a very different scale. And so when we think that there's something going on, we certainly need to get to the doctor. And more than likely, we need a referral. We will need a referral to see a neurologist if we're really concerned. One of the things, too, and I didn't say this, but the Alzheimer's Association suggests that about 40% of the time, doctors will not give you a diagnosis. And so that is a frustration for families. So we share that you should really be persistent. Get that diagnosis if that is what you need. Now, some people say they don't want a diagnosis, and I can understand that. We encourage diagnosis. And let me tell you why people some of the reasons people don't want a diagnosis is because we don't have a cure. We don't have a drug that will slow it down. We have drugs that will help ameliorate some of the signs, some of the symptoms, but we do not have a drug that will slow the disease down. So some people feel like, well, what can I do? I think we talked about that this morning. What can I do? So why would I need a diagnosis, really? And so when people ask us, why do I need a diagnosis, we begin to say, well, you can begin to make plans with the family. You can find out what you can do as a family. But some people just find that it would be absolutely frustrating to get that diagnosis. Long answer, I'm sorry.
Great answer.
I have a question because it looks like it takes a lot of leadership to do what you did. I have the feeling that you engage all the world around you. So the question is simple: how many people was the group which started the whole project?
Right now?
No, on the beginning, when
Okay.
everything was going, how many people really started to do this job? Because as I said, and so of your talk was like this literally whole world around.
Right. Oh, no, it's a small world. It's a small, small world. Actually, there were 3 of us. So initially, there were 4 institutions, and each one of us sort of divided up the recruitment. We decided that we needed more. And by the way, my institution is, we're a historically black university. So we sit right in the heart of a huge black community. And yet we were sort of in our silos on campus because we weren't doing this kind of research. So we felt like, even though we were a black university, we're in the black community, black PI, I knew I couldn't get these participants unless I did something extra. So we started with 3 people for my site. 3 people. That was a lot of words, and all I needed to say was 3. I'm going to do better, I promise. Yes, ma'am. Yes.
Is there a difference between Alzheimer's and dementia?
Yes. Yes. So Alzheimer's is just the most common form of dementia. You might have missed my umbrella because I probably went by it kind of fast. So when we think of dementia, we just think of confusion, some memory loss, some interference with our activities of daily living. It could be any number of things that cause that. I'll tell you a quick story. My grandmother, who died at 102, when she died, she was taking only aspirin and gas pills. She was a pretty healthy lady. But that was her medicine, and she had to take it on time every day. But unfortunately, she took too much aspirin. She was on a big dose. And she became just as confused as she could be. We thought she had some kind of dementia. We thought she had some kind of, we didn't know what was going on. My husband was actually a physician, and he actually saw her medicine. He said, Miss Smith, let me see her medicine. And she said, oh my God, she's taking too much medication. So she had the same kinds of issues. And once they began to tamp that aspirin down, she completely turned around. With Alzheimer's, you don't turn around. It doesn't get better. With some dementias, you can get better. So Alzheimer's is just one type, but it's the most common type. Been around a long time, though. It was discovered in 1906. As a matter of fact, it's been around a long time, and it was around before that. That's just when Dr. Alzheimer's discovered it.
Well, I was asking because I've never noticed in any of my family, I've never noticed any of them happening.
Oh, bless you. Wonderful, wonderful, wonderful. I hope that's the case long into the future.
Yes, what's the question?
Is there any evidence that there is a variance between race, ethnicity, in terms of onset and duration of Alzheimer's?
In terms of duration? Oh, that's a great question. In terms of duration. In terms of duration, I don't.
In other words, between onset and death.
And death. I don't know. That's a great question. Does anybody else know the answer to that? I'd like to know that. I'll see if I can find out, but I really don't know the answer to that. But you had an idea. What was your idea behind that? What did you have?
Well, I was just wondering if that, since there is genetic dispensation, this disposal is not
We understand. There could be.
And you pointed that out in family.
Mhm.
I was just wondering if there was any evidence of racial, ethnic, or maybe even national origin in terms of incidents, onset,
And time to death. I don't know about that. And I'm going to look that up to see if I can find the answer to that. But I really don't know. Would be interesting to know, though. Thank you for that. Yes?
Since you indicated that you need certain legal documents, power of attorney directly, how do you engage with the legal community in your city?
In our setting? Yes. So we do not, in our center, we only have 14 people, and only about half of those are full-time. So when there is a need for something, we have wonderful volunteers. And so we know how to get an elder law attorney over. We go to our school of business, our college of business, to get someone to talk about certain things. So in our center, we do not have that expertise, but we do have a wonderful network of professionals that we call on all the time. Our stakeholders. Yes, thank you.
Well, thank you for the outstanding lecture. It's
Thank you.
really shows how much efforts, commitment it takes to achieve this. This is not something that takes days or weeks.
No.
But what surprised me though is at the beginning, there was only some of the participants. They mentioned that only 5% of them get information from the churches. That is really shocking finding, because at least in Galveston here or around here, there is a very close involvement of the faith community.
Yes.
In our community-based Alzheimer participatory research and education. Indeed, we even traveled to Navasota, some place called Kamalen, which is a faith base. So it's amazing, and I'm wondering if you're able to move that.
Yes.
It's one opportunity to really get the messages out.
Absolutely. Thank you for asking that. And so we actually brought a pastor on a consultant basis. So we brought an African-American pastor on as a consultant, and then now he's on our advisory board to move that needle. Our COAACH Caregiver curriculum also is a faith-based initiative. So absolutely. Now, we intentionally didn't go to the church first for obvious reasons. Maybe it's not so obvious. But we did not go to the church first because so many of our churches feel like that's what we researchers do. We come to their churches, we pray on them, and then we leave. So we intentionally did not go church first, but now you better believe we're all over the churches. But it's easier now because they know who we are. But yes, and we were very struck by that as well. It's much different now with the people that we survey. And we do this survey every year.
I gotta say that here on Galveston Island, the churches are also well aware of what's going on in the center and aging due to the work that the Reverend Ellen Appleberg is here again with us.
Yeah. Yeah.
And she's done a fantastic job over the past almost 20 years with us, and she started with Dr. Goodwin, and so there's been a lot of work also from the center on aging.
It is a great place to really establish some good relationships, and we have done that. And remember now, this was about 15 years ago, and people didn't talk about Alzheimer's. I mean, we suffered with Alzheimer's, but we didn't talk about it much.
That's a two-part question. One
Yes.
Are there any environmental differences, because you keep talking about North Carolina, and the question is, would your results be any different if you were studying a similar population in, let's say, Utah? Or that's one part of it, and the other part of it is how much does multi-ethnicity play into?
Right. So I'll take your last one first. So multi-ethnicity is something we have to be concerned about. We do have software to sort of tease that out when we self-report that. But with regard to and more, we're becoming much more diverse. So we have to continuously think about, we have biostatisticians on our genetics work who actually look to tease out those effects. The first question is around the environment. And so when we study a disease like Alzheimer's, which is so very complex, and in most diseases, quite frankly, we have to think about environment. We have to think about environment, gene interactions. And so when we look at different environment, and we also look at what is called social determinants of health. That means where we work, where we play, where we stay, the stress, the education levels, socioeconomic status, discrimination, poverty, all those things play into disease. How that plays into what we know about Alzheimer's disease it remains complex, but we know for sure that those social determinants of health absolutely impact not only our genetics, but in many cases the severity of disease. So yes, so it may be. I talked to one faculty member today from China. Is she here? And she was just talking about some of the differences there. Then those things need to be looked at. And different populations have different disease. We respond to medicines differently. So yes, our environment is very, very important. Thank you.
Thank you very much.
You're quite welcome.
UTMB Health, working together to work wonders.